Thank you. Welcome very much to this seminar, which is on myocarditis. As you'll all be aware, during the last few months, myocarditis has been a massive challenge, particularly with COVID, but it's one that we've lived with for many years. My name is Sanjay Prasad. I'm a cardiologist and professor of cardiology at Imperial College, and we have a wonderful lineup of colleagues that will talk about different aspects with a particular focus on living with myocarditis and the advice that we give to patients. I'd like to introduce one of our sponsors for the meeting today and someone who's really spurred this meeting and the reason why we're holding it, and that is Andy Janssens from the Janssens Foundation. Andy, if I may introduce you, please.
Yeah, thank you so much, Sanjay. So I'm Andy Janssens, and I'm from the Alexander Janssens Myocarditis UK Fund. We're so excited about this evening, actually, because we've been working almost now for 10 years to get myocarditis on the agenda. There's been some great research papers leading to some lovely and fantastic potential outcomes, which I won't go into now because I'll be stealing other people's thunder. But so we're 10 years in after, well, almost 10 years in after losing my middle son, which spurred us to do something about myocarditis, which, when we were doing some early research, most people consigned it to what they called a dustbin, i.e. they didn't understand it, they couldn't diagnose, and they didn't know what to do with it. So today is a massive step forward. Thank you so much, and I look forward to listening to the presenters during the course of the evening.
Thank you very much, Andy. So I'd like to welcome our first speaker, Dr. Amrit Lothar. Amrit is a consultant cardiologist at the Royal Brompton Hospital and at Imperial College, and he's going to kick off by telling us what is myocarditis, how do you diagnose it, something about the epidemiology. Amrit, over to you.
Thank you. Good evening, everyone. I'm just going to share my screen. Okay, hopefully you can see this. So the title of my talk is Diagnosis, Epidemiology and Treatment in Acute Myocarditis. So it's quite a lot to fit into a talk, and we'll try and see how much we can get through. So myocarditis refers to inflammation of the heart muscle. It's something, inflammation itself is something we've understood for many, many centuries. So inflammation is essentially the heat, the pain, the redness, the swelling. This happens in response to any sort of insult anywhere in the body, and that's something that is well known. And this also happens in the heart in myocarditis. Myocarditis can be due to many different causes. It can be due to viral infection, and the figure here just shows how our understanding of the different viruses causing myocarditis has increased over time. So initially, fairly limited understanding, but more recently we've began to look at COVID-19 and parvovirus and human herpes virus and lots of other things as well. Also, lots of different drugs and toxins can cause myocarditis, as well as autoimmune conditions as well. We also know that myocarditis is increasing in prevalence across the country and indeed globally. There's some data just shown here on a figure, which we'll talk about in more detail shortly. But the red line is the number of cases of myocarditis in NHS England. These are all hospitals across England. And you can see over the last 20 years, there's been a fairly steady but increasing increase in number of patients with myocarditis. Most patients tend to present with chest pain, around 85 to 95% with chest pain. There are, of course, other presentations as well. And in terms of outcomes, we know that up to a quarter can go on to develop some kind of heart dysfunction, which we call dilated cardiomyopathy. And this can be the leading cause for needing a heart transplant. And the figure at the bottom here just shows some of the different trajectories a patient can take. So over time, heart function can initially decline, and then it can recover again in many patients. But in some patients, it can decline and then decline further. And really, there's been a lot of work to try and understand what makes these individuals different. We also know that myocarditis is sadly an important cause of sudden cardiac death, particularly in the young. And so taking all these factors into account, myocarditis really is an important diagnosis and not to miss, and there's been lots of recent efforts to try and improve our understanding of it. So we'll start with epidemiology. So looking at national registries, we know that myocarditis occurs in around 15 to 22 cases per 100,000 people. So there's lots of data from Finnish military personnel where they've collected records diligently for around 20 years. And also in the WHO Global Burden of Disease study, where we see approximately 1.5 million cases globally in the 2013 calendar year. With our data, we've looked more closely at what's been happening within NHS England, so really harnessing the power of the NHS and how all of the data is collected centrally. And what we've been able to show is that the blue line represents the number of cardiology admissions as a whole. And as you can see, that's increasing over time due to an aging population, a growing population. But it's really the red line that you're interested in. So this is the number of myocarditis admissions. And you can see the rate of increase going up in recent years, around 2,000 admissions per year and climbing. We've looked at these patients in more detail, and we've gained a few insights there. So it seems to be that 2/3 of all patients affected are male. And on the figure shown here, you can see that these patients tend to be young men aged around 20 to 35, which is the big peak here on the screen. I'll just pop this on. Whereas women tend to be affected later with a median age of around 46 years. There's lots of different potential reasons for why that may be, differences in sex hormones, immune responses, but it's important to study that further. We also know about seasonal variation. So there is a peak in myocarditis admissions in March, and a further peak that normally tends to happen in sort of late October, November time. And again, you can see the green bars represent women, the blue bars are men, twice as likely. And this very much copies and mimics what we see with influenza, and again, more recently with COVID as well, just reflecting that the majority of myocarditis tends to be due to a viral etiology, a viral cause. We've also looked at geographical variation. So looking at all of these admissions up and down the country, we found that most of them have tended to be in and around London. So 27%, but we know London only accounts for 16% of the national population. So there are lots of potential reasons for this. Could it be to do with population density? Are there other socio-economical factors, effect of migration? Lots of questions. But another potential reason is the fact that in London, we probably do have better access to cardiac MRI. We do have many of the high volume centres scattered around, a very small area in central London. And it's really the cardiac MRI scan, the image just shown here, shows a patient with myocarditis affecting one of the heart walls. It's really that ability to clinch a diagnosis, which probably affects the way these diagnoses are then recorded. We've also looked at subnational variation. So just diving into the data a little bit further and looking at London specifically, we can see that across all the different London boroughs, looking in 2017 and 2018, we see that some boroughs seem to have more myocarditis than others. And again, this just raises further questions. This isn't simply due to population density, because the diagram at the bottom there shows that most of the patients tend to be clustered around the more central parts, but we're seeing an overrepresentation in some of the surrounding boroughs. And then, of course, there's the impact of COVID-19. So we've looked at, we've extended our data collection to look at what happened to myocarditis admissions in response to COVID-19. And what you can see, the green line represents the overall background number of COVID-19 cases. This is the first lockdown in 2020. And you can see from the orange line, the number of myocarditis admissions fell around that time. And I think that's sort of the theme with most hospital admissions. Patients were advised to stay away from hospital. There was the fear of catching COVID. And what we did see in the patients that did go into hospital, they tended to be slightly older. And so only time will tell whether there's been any sort of long-term impact of potentially patients not going into hospital with their myocarditis during this very difficult period. Moving on to diagnosis. So myocarditis is one of those conditions that can present in many different ways, and diagnosis can be challenging. We usually take a stepwise approach. All patients will have an ECG and a troponin, so that's a marker of some of the heart muscle protein in the blood. And if we do see any abnormalities, and we can't explain them by the presence of coronary artery disease, it's then important to look a little bit more closely, and patients often then go on to have an echo and further cardiac MRI investigation. And the cardiac MRI is really important, as we'll see, because it allows us to look at things and changes happening within the heart muscle. Endomyocardial biopsy is also an important technique. It has its place in myocarditis, but tends to be reserved for a smaller number, the more severe presentations. And an FDG PET scan is also useful to look at inflammation, but mainly restricted to certain patient populations where we think there may be a systemic autoimmune condition, and we want to look at other organ involvement. So when we look at our cardiac MRI scans, we focus on these three parameters, which were introduced in, or sort of diagnosed or described in 2009. They were collectively referred to as the Lake-Louise criteria. So we're looking at the presence of at least 2 out of 3 of these features. So these are all the same patient, the same view of the heart, looking at the left ventricle. The first sequence here is programmed to look specifically for water. So we're looking for increased water content within the heart muscle, and we can see these regions lighting up. So these are the regions affected by myocarditis in this patient. We then give contrast, and we look to see where it arrives first within the heart muscle. And again, we see these same regions, and that essentially tells us that that region of the heart muscle is swollen and it's red. And then we look at scar formation, and again, the same regions hold on to that contrast and light up, telling us that that's also a problem area. We can then also go a little bit more into detail and look at the patterns of myocardial involvement. So we know that patients presenting with acute chest pain commonly have parvovirus B19 as their cause, and this tends to affect the lateral wall of the heart. So this is a cross-sectional view from the last image, and it's its side wall here that is affected with that particular presentation. And these patients tend to do well in general. Patients with more heart failure presentations tend to have human herpes virus 6, which affects the septum of the heart, so this region here on this diagrammatic representation. And it's also worth bearing in mind, sometimes we do see on the scan quite extensive scar formation, and sometimes that raises the possibility of whether there's an underlying heart muscle disease separate to myocarditis, but overlapping with myocarditis. So in this patient here, we see lots of scar, almost all the way around the heart muscle, and that could potentially indicate an underlying arrhythmogenic cardiomyopathy. And we've done some recent work that I'm sure we'll discuss later, which suggests that a large number of patients with myocarditis may have an underlying cardiomyopathy. More recently, T1 and T2 mapping techniques have taken another step forward. So using T1 and T2 parametric mapping. So here what we're able to do is convert our grayscale images into these colorful mapping images at the bottom. And these images are colorful because they actually contain more biological information. So each pixel has a value which can then be assigned a color. And this allows us to really measure what's happening within the heart in greater detail. And that's really important, because unless we can measure what's happening within the heart muscle, we can't really study it or improve it. So there have been a number of studies that have used these recent advances. On the left here, in patients with acute myocarditis, we don't need to look too much at the detail, but you can see from the purple line, the patients that have more, have higher increases in their T2 mapping times tend to do worse compared to the ones that have less of an increase in their T2. And so, you know, it makes sense intuitively. The more water content you have, the more swelling you have, the more intense the inflammation, and potentially the worse the longer term outcome may be. And that's also recently been shown also in immune checkpoint inhibitor myocarditis. So these are drugs used in various different oncological therapy that can also cause myocarditis. So this is all really important, and as a result, the Lake-Louise criteria that I mentioned from 2009 were updated in 2018, taking into account these recent advances. And so now patients are required to demonstrate myocardial edema by either the original technique or by T2 mapping, as well as a non-ischemic myocardial injury by T1 mapping. And this can all be supported by the presence of other features like pericarditis, which often occurs with myocarditis, or any systolic dysfunction, so any impairment in heart muscle function. So the endomyocardial biopsy is potentially a more controversial area. According to the current European guidelines, it should be the gold standard in every patient presenting with myocarditis. It of course has its use. It provides a detailed assessment of what is causing myocarditis, and it can really pinpoint the exact cause, which can then direct management and tell us a little bit about longer term risk. And that of course is very useful information to have. However, it does carry a significant risk embarking on an endomyocardial biopsy in terms of taking pieces of heart muscle from the inside. And of course, we know myocarditis is a focal condition. It can affect different regions of the heart. And so it is possible that when you use a biotome to collect small pieces of heart muscle, which are in the order of a couple of millimeters, it's very easy to miss the myocarditis altogether. And when you do manage to look at that sample in the lab, it's also very difficult, and there has been a lot of work to try and improve the way in which histopathology is performed on these specimens to improve the interpretation. And all of that together has really led to quite wide variation in how we use endomyocardial biopsy. And in a national survey done in 2017, out of all of the biopsy procedures done across the UK, so 717, less than 1% was specifically done for myocarditis. That's probably an underestimate, but does give you some scale of the number of these biopsies done for myocarditis. Just a quick nod to the future, potentially microRNAs could change the way we diagnose myocarditis. So there was a recent study published in the New England Journal of Medicine that looked at the presence of these small non-coding RNA molecules. These are the small proteins that essentially regulate the way genes are expressed within the heart. And the figure on the right is sort of the most exciting bit, which shows that in acute myocarditis, this non-coding RNA is more prevalent compared to in patients with acute myocardial infarction or healthy volunteers. And so it's that ability to differentiate myocarditis from other pathologies also presenting with chest pain that is really interesting. And potentially in the future, this finding could be filtered down into point of care testing, which could be done at the bedside, out of hospital, to provide a rapid diagnosis of myocarditis. So then moving on to treatment, this section is slightly shorter because we don't really have that much evidence-based therapy for myocarditis. Most patients are usually admitted to hospital for monitoring due to the potential risk of deterioration. Supportive management is really the key. Focus on withdrawing the cause if possible. So for example, stopping any potential drugs that might be causing myocarditis, like immune checkpoint inhibitors, clozapine or other drugs. And then addressing any complications. So if heart function is reduced, then using appropriate guideline-directed medication to address that. Or if there's any heart rhythm disturbance, and beta blockers and other therapy again to counteract that. Non-steroidal anti-inflammatories aren't routinely used, unlike in pericarditis, due to the potential of harm, particularly where heart function is reduced. And that's really based on animal studies done many years ago. Colchicine is sometimes used, particularly if there's a concurrent pericarditis, and that can be quite effective. And the general advice is to avoid any exercise for at least 6 months, just to allow the heart to recover and avoid precipitating any other complications. And I'm sure we'll hear more about that later. So immunosuppression, in terms of switching off the immune response, is something we do, but in very specific settings. There's a good evidence base for using immunosuppression in giant cell myocarditis or eosinophilic myocarditis or in cardiac sarcoidosis. The benefit is unclear in the setting of acute viral myocarditis, which is by far the most common presentation. This table is slightly busy, but if you just focus on the red box, it very nicely summarizes our current understanding of treatment in myocarditis. So in patients that have inflammation and have a virus within their heart muscle confirmed on a biopsy, you'll see lots of question marks. We don't really have a robust evidence base to guide whether or not we should be using any antiviral therapy. whether we should be using any kind of immunomodulation or immunosuppression. And so for most of these patients, as I've mentioned, the treatment tends to be supportive, addressing any complications as they arise. The other sections here just relate to if you manage to clear the inflammation and clear the virus, but you still have reduced heart function, potentially some consideration needs to be given as to whether you have an underlying genetic cardiomyopathy. And in the middle, these areas are slightly more controversial. If you have cleared the virus, but you still have ongoing inflammation, in the setting of lymphocytic myocarditis, there's slightly conflicting evidence as to whether or not immunosuppression is beneficial. In the future, again, potentially there are a few things on the horizon. So interleukin-1 is a pro-inflammatory cytokine. So in response to any damage, interleukin-1 is released to then trigger an inflammatory cascade, which ultimately leads to all of the other downstream effects that we've already mentioned. And blocking interleukin-1 has shown benefits in a phase 3 randomized trial in recurrent pericarditis, not myocarditis. And you can see from the curve here, patients that received this new drug didn't suffer with a recurrence of pericarditis. And that, of course, is potentially life-changing for these patients. In myocarditis, we know, of course, that damaged cardiomyocytes will also release interleukin-1. And the question there is, potentially, could similar therapies also reduce the inflammatory response in myocarditis? And would that be a helpful thing to do? So further research is needed to look at that in more detail. So this has been a whistle-stop tour, and I'll come swiftly to the conclusion to keep the time. So myocarditis is an increasingly prevalent condition, and hopefully I've shown some insights into that. And I think improvements in diagnostics in recent years should enable better subclassification. We call that phenomapping in due course, and that really allows us to unpick the different types of myocarditis rather than using it as one umbrella term. And ultimately, that will hopefully lead to more evidence-based approaches and targeted therapy in the future. I'll leave it there. Thank you very much for your attention.
Emma, thank you very much for that excellent overview. So I'd now like to introduce our next speaker, and that is Professor Leslie Cooper. Leslie Cooper is probably one of the biggest names in the field of myocarditis, and he's going to talk about COVID and the impact on its heart. Where are we 2 years on from the start of the pandemic? For logistic reasons, we agreed that Leslie would give a pre-recorded talk, and we will now switch to that. Thank you very much.
Hello, I'm Leslie Cooper, the Chair of Cardiovascular Medicine at the Mayo Clinic in Florida. I'm delighted to be with you. I wish I could be there in person. I've been asked in the next 15 to 20 minutes to review the effects of COVID-19 on the heart, both acutely and in the longer term. So I'm going to share my screen, and I have no relevant relationships specifically related to COVID-19 and the heart to disclose. Those are my other financial relationships. We're going to cover 3 topics in the next 15 to 20 minutes: COVID-19 with respect to acute cardiac injury, the mRNA vaccine-associated myocarditis, and the heart and long COVID. In the beginning of the pandemic, there was a lot of terrible illness associated with acute ICU stays, intubation, ventilation, and frequent cardiovascular death in older individuals. In the beginning, we didn't know whether this was going to be caused by more thrombotic processes, such as acute myocardial infarctions, or large vessel venous thrombosis, or perhaps even myocarditis or a stress cardiomyopathy. All of these were observed in small case series. As it turned out, thrombosis was relatively important, and classic myocarditis was not very important. The early studies noticed on biopsy and autopsy that it was the mononuclear cells, here illustrated with in situ hybridization, that contained the SARS-CoV-2 virus at about 1 cell per square millimeter or high-powered field. The myocytes were not typically involved. In this review paper from January of 2021, only 4.5% of patients who died from SARS-CoV-2 had any histologic evidence of myocarditis. The vast majority did not. And that led to a disassociation between the findings on MRI, which were relatively common in the older, sicker population, and the findings on histology. This figure, published earlier this year, summarizes some of the findings that we see on cardiac MRI following acute SARS-CoV-2 infection. You can see a subepicardial myocarditis illustrated at the top left with delayed enhancement and normal myocardium underneath toward the endocardium. You can see a transmural infarct, which could be due to thrombosis of a large artery. There's a mid-wall pattern of non-ischemic cardiomyopathy, as well as a subendocardial non-vascular distribution of delayed enhancement that can be seen with microvascular thrombi, as well as normal variants. All of this suggests that there is more than one mechanism which underlies cardiac injury in the acute setting. There have been a large number of MRI studies published. I'm only going to cite a couple of them. The first, from London, by Kotecha et al. Last year, looked at 148 subjects from 3 hospitals. They were older individuals, elevated troponin, and they were imaged about 2 months following the acute injury. Overall, a bit more than half, or 54%, had abnormal cardiac MRI findings on blinded review. About half of those were inflammatory, and about half were ischemic. In younger individuals, the rate of cardiac MRI abnormalities is much lower. You can see here in this more recent study from the United States, the Big Ten sports teams had an MRI registry, and they looked at 1,597 college athletes, mostly men, who were SARS-CoV-2 positive. Many were asymptomatic. The rate of abnormal findings on MRI was only 2.3%, and only a quarter of those, or 9 out of 1,597, were actually symptomatic. So, in the acute setting, we found that although there's a wide pattern of injury, most people do recover, but more recently, in the past year and a half, there's been a substantial debate regarding the relative value of mRNA vaccines because of a reported rate of myocarditis, particularly after the second mRNA vaccine in young males. Let's look at those data. The first large cohort to be reported, we reported from the US military. And in that study of 2.8 million doses of mRNA vaccine, both Pfizer and Moderna, there was a elevated rate of myocarditis observed by cardiac MRI and on clinical review of the actual case records in young males. It was the males, and primarily those after the second dose, where there was about double the expected rate of myocarditis. All of these individuals did well and got better. The second group of papers came out of Israel, and they demonstrated that there was an elevated rate of myocarditis, illustrated where the red arrow you can see in green, there's an elevated 3 per 100,000. However, it was much lower than what was observed with the actual viral infection itself, about a quarter of the expected rate. And most importantly, there were a very large number of arrhythmias seen over here in the SARS-CoV-2 exposed group, compared to actually a slight decrease in arrhythmias in the vaccinated group compared to expected. Many other countries, the United Kingdom, Denmark, Ontario, Canada, reported their results. These data are from the United Kingdom, approximately 40 million individuals, and showed that the rate of myocarditis following a SARS-CoV-2 positive test was about 40 per million, and that the rate following an mRNA vaccine with Moderna was about 10 per million here. In the age under 40 group, the rate with the Moderna vaccine was higher, and it was still detectable then with the Pfizer vaccine illustrated in blue. However, the rate of pericarditis was elevated, particularly after SARS-CoV-2, and the rate of cardiac arrhythmias, as in the Israel data, was much higher, as you can see on the far right, following the actual SARS-CoV-2 infection compared to vaccination. Turning to the United States, we have a lot of data from the VAERS registry, as well as this PCORnet, which included 6.7 million vaccinees and 814 SARS-CoV-2 positive subjects from 40 US sites. In the males specifically, ages 5 to 11, there was a 12 to 17 per million rate of myocarditis diagnosed or pericarditis diagnosed after the actual SARS-CoV-2 infection. This was much higher than was seen after the first vaccine dose or after the second vaccine dose in the first column on the right, first row on the right. The age, as you increased to puberty, had an increase between ages 12 and 17. There was a much higher rate of SARS myocarditis or pericarditis after SARS-CoV-2, between 50 and 64 per million. But the rate after the first and especially the second vaccine dose also increased somewhat to 2 to 3 per million after the first dose and 22 to 35 per million after the second dose. Again, a bit lower than was observed after the actual viral infection. After age 30, when males have lower testosterone levels, the incidence of SARS-CoV-2 infection-related myocarditis was still increasing, but the incidence after the vaccine first or second dose in the bottom row was actually decreased again. And so that led to this analysis published earlier this year that suggests that even in young male individuals, the benefit of the vaccine, as illustrated here, is greater than the potential risks. What about long COVID? Long COVID is now a substantial issue in many of our clinics, and there are symptoms that span all organ systems. You can see in this figure that cardiovascular symptoms, which include tachycardia, palpitations, chest pain, or dyspnea with exercise intolerance, are common, but not the only symptoms. Other papers looking at multiple organ systems have described an association of elevated anti-spike protein antibodies with greater number and severity of cardiac and non-cardiac symptoms. Specifically, cardiac symptoms have been analyzed in a number of data sets. This one, most recently from the US Veterans Administration, looked at 153,000 individuals with COVID-19 who survived more than 30 days. The risk of cerebrovascular disorders, dysrhythmias, and myocarditis and pericarditis was all elevated in those individuals who survived SARS-CoV-2 and would be considered long COVID or long haulers. And this was true even in those people who are not hospitalized. This figure from the same paper gives you a better sense of the magnitude of the risk in for each category of disorder. The third column or third row, inflammatory heart disease or myocarditis and pericarditis, had a substantially elevated relative risk at 2, but the absolute number of cases was quite small. Compare that to the second row, dysrhythmia, where you had a smaller, slightly smaller relative risk, but the absolute number, the excess burden per 1,000 persons was almost 25. Again, consistent with the Israeli and the English United Kingdom data. So why is this the case? We don't know. This is one of a number of smaller studies that tried to look at mechanisms in 48 patients who were 6 months after hospitalization for symptomatic COVID. About a third of those had elevated troponin acutely. Slightly over half had persistent shortness of breath at 6 months with a normal resting echo. And in those who had been troponin positive with low-level exercise of 25 watts for 3 minutes, there was increased stiffening and higher pulmonary artery pressures, again suggesting a possible mechanism for these symptoms. About 4 weeks ago, Dr. Puntman and colleagues from Frankfurt, Germany, published this paper on the MRI-based imaging features associated with long COVID symptoms. In 346 individuals who were out 109 days following COVID infection, 73% had cardiac symptoms, including dyspnea, palpitations, atypical chest pain, and syncope. Their primary observations were that there was a higher native T2 value, which is a metric of myocardial edema, in those participants who had persistent symptoms compared to those who became asymptomatic. And in a multivariate model, female gender and increased native T1, which can be associated with inflammation or scar tissue, at baseline predicted cardiac symptoms at follow-up. I would note that there are many other large MRI-based registries looking at similar questions that we hope will be published in the months to come. In summary, this is the current recommended guidelines for the management of evaluation and management of post-COVID symptoms. It's a bit complicated, but if we start at the left, there are COVID-19 symptoms which span from asymptomatic all the way to lifestyle limiting symptoms. And it depends on the severity of the symptoms how you will do the evaluation. All patients are recommended to have an EKG, troponin, and echo. And if those are abnormal, move on to a cardiac MRI with tissue characterization that includes native T1 and native T2 mapping sequences. If there is a diagnosis of myocarditis, abstinence from sports can be considered. I believe the next speaker will be addressing return to play, as illustrated here in the bottom right. And so in summary, classic myocarditis is uncommon in COVID-19, but there is a gap because there are other mechanisms that may be accounting for the higher rates of MRI-based abnormalities that we are seeing acutely, thrombosis and other novel forms of inflammation. MRI vaccines are associated with a small increased risk of myocarditis, particularly in males after the second dose, below age 30, but most of these cases are mild, and the net benefit is in favor of vaccination. And finally, cardiovascular symptoms more than 3 months after COVID constitutes the PASC or long COVID syndrome, and there are many studies ongoing to sort out the reasons for this, but the greatest burden, I would note, in patient-reported outcomes is both anxiety and depression, which far exceeds the burden of cardiovascular disease. With that, I would say thank you very much.
Leslie, thank you very much for that wonderful overview. We're really, really grateful. I note that many of you are adding your questions to the chat. Please do add those, and we'll make sure that we leave enough time to try and address as many of them at the end. When we think about myocarditis, one of the big challenges is really exercise and how to resume to exercise. And I'd now like to introduce my co-chair, Dan Sado from King's, who's going to introduce our next speaker.
Thanks, Sanjay. Yeah, I think that's spot on right. Leslie's alluded to it and Sanjay as well. And I can say from my own experience, 8 hours ago, I think I was on a ward round at King's talking to somebody about exercise and what to do in myocarditis. So delighted to welcome Sabir, who trained in South London and originally started off in inherited heart disease with Sanjay Sharma, and many of the medics and cardiologists on the call will know Sanjay also does a lot of sports cardiology, and so of course Sabir has been very well trained in sports cardiology on the back of all the inherited stuff as well, and of course has now gone on to the Brompton to become a consultant where she practices in sports cardiology. So we're very lucky to have you speaking to us today, Sabir. Thank you so much.
Oh, thanks, Dan. Thanks, Sanjay. Right, I'm just going to share my slides with you. Okay, you can see my slides, I hope. Okay, so I'm going to be talking about returning to exercise after COVID-19 related myocarditis. I have no disclosures. So we recognize that infection with SARS-CoV-2, also known as COVID-19, is associated with a high prevalence of myocyte necrosis in those who are acutely unwell or who require hospitalization. And most of these individuals are elderly, have cardiovascular comorbidities or risk factors for atherosclerosis. Now, we also recognize that the possibility of a raised troponin is multitude and can be associated with a response to systemic inflammation. It can be associated with a direct myocardial infection, that is myocarditis. It can be associated with a stress cardiomyopathy. We may see myocyte necrosis due to profound hypoxemia. We may even see myocyte necrosis due to plaque rupture and a hypercoagulable state. And we may also see right ventricular strain or damage from pulmonary hypertension. And what causes us concern is the possibility of myocarditis in our athletes. So we've heard that myocarditis is an inflammatory illness due to the virus. It's associated with viral replication and myocyte necrosis. It's followed by an inflammatory phase, which varies in duration and magnitude, and finally a chronic phase. And we know that that in the short term, myocarditis is associated with a high morbidity and mortality, but we do also know that 50% will demonstrate full resolution within 30 days. 25% will go on to develop persistent cardiac dysfunction, and 12 to 25% will develop cardiogenic shock or fulminant heart failure. Now, an impaired left ventricular systolic function, complex ventricular arrhythmias, and a low cardiac output is associated with a bad prognosis. Athletes behave differently to the general population when it comes to COVID infection and myocardial involvement. One, because they are young, they have a normal body mass index, they have fewer risk factors for atherosclerosis, they don't usually have cardiorespiratory comorbidities, they have a better cellular and humoral immunity, they have a reduced systemic inflammation and a better organ perfusion. But we do worry about subclinical infections in our athletes because murine studies have demonstrated that intensive exercise on an already inflamed myocardium will result in a protracted inflammatory phase, and this can be potentially be associated with extensive myocardial fibrosis and complex ventricular arrhythmias. Indeed, sudden cardiac death due to myocarditis in our athletes is well recognized. Sorry, I've missed a slide, bear with me. And we know that myocarditis is implicated in 5 to 15% of all sudden cardiac deaths in young athletes, and it accounts for up to 20% of sudden cardiac deaths in military recruits. So the question we have to ask is, how do we best diagnose myocarditis in our athletes with COVID-19 infection or any other viral illness in the most cost-effective strategy? So here are all the potential methods of diagnosis. I can certainly tell you that the clinical features are variable with this condition. Viral serology is actually unhelpful because it takes ages for the results to come back. Biomarkers of cardiac damage can be helpful. The ECG has a sensitivity of less than 50% in such cases. The echo is usually normal in mild cases. It's only really helpful in your severe cases. As we've heard, cardiac MRI is probably your most useful investigation and informs decisions, and I will cover this again. And cardiac biopsy is, although is the gold standard and is the most specific investigation, it is reserved for a limited group of individuals, particularly those in cardiogenic shock or fulminant heart failure, and it doesn't really apply to our athletes. So the assessment may not be so straightforward in our athletes because although measuring troponin levels sounds wonderful, the upper levels of troponin are based on the general population, and we don't actually know what the norm in our athletes is. So our athletes who exercise, even particularly when they're unwell, their troponin levels could be elevated for up to 48 hours. So it doesn't really help us in this situation. We also know that ECG changes such as ST elevation, tall T waves, inverted T waves are identified both in our athletic cohorts as well as patients with myocarditis. Echo can be helpful, but you need to remember that some of our endurance athletes will have large LV cavities, borderline low ejection fraction, which is a part of a normal physiological response of intensive exercise training. Clearly, MRI is the gold standard, but there is an absence of normative data, and some of our middle-aged endurance athletes will also have SCAR. Now, I know Amrit has covered this already, but I would like to just go through it again. We do use CMR for the detection of myocarditis, and we use the Lake-Louise criteria, which is associated with more than 80% diagnostic accuracy. And what we require is one criterion out of each of the following two categories. So myocardial edema and non-ischemic myocardial injury. And in myocardial edema, you're looking for regional or global increase in your T2 signal. Also, we identify regions of hyperenhancement on T2 weighted images or quantify it with T2 mapping. And I guess T2 mapping is specific for edema and it's excellent for your acute myocarditis. In terms of non-ischemic myocardial injury, again, where you're looking for regional or global increase in your native T1 or your extracellular compartment. And T1 mapping is the most sensitive marker of inflammation, and it's excellent for ruling out inflammation. We are also looking for myocyte necrosis with late gadolinium, and we're looking for certain patterns such as a subepicardial distribution or a mid-wall distribution to suggest myocarditis in the clinical context of a viral illness. So who gets a CMR following a COVID infection? Well, we'd certainly consider it in individuals with symptoms consistent with cardiac involvement, those with novel repolarization ECG changes. So from our experience, around 3% of our athletes where we have a baseline ECG demonstrate new changes. And when they go on to have an MRI scan, our diagnostic yield is around 80%. That is for myocarditis or pericarditis. Certainly, we would consider doing an MRI in those with a raised serum cardiac troponin 48 hours after complete rest. And clearly, an impaired LV function or pericardial effusion is a clear, strong indicator for a cardiac MRI study. Now, this is probably one of the best studies out there evaluating the prevalence of myocarditis in our athletes, how to detect it, how to use CMR. So the authors in this study looked at just over 3,000 athletes with a mean age of 20 years. 119 had a clinically indicated CMR based on symptoms or an abnormality in one or more of cardiac troponin, ECG, or an echocardiogram. And they compared them with 190 individuals who underwent a CMR as part of a mandatory assessment by the club. Now, what they found was that none had a severe illness. 13% had symptoms consistent with a possible cardiac involvement. 2.7% had one or more abnormalities in terms of symptoms, cardiac troponin, ECG, or an echocardiogram. And the prevalence of an abnormal CMR consistent with myocarditis was 0.7%. That is to say, 1 in 5 individuals with abnormalities in terms of symptoms, troponin, ECG, or an echo, if you went on to do a CMR, they would have myocardial involvement. Reassuringly, though, cardiac symptoms were the best predictors of probable or definite cardiac involvement. So for future streamlining of who needs a CMR, will be guided by symptom evaluation. So what are the implications of myocarditis in our athletes? Certainly, once you diagnose myocarditis in your athlete, you need to really rest their hearts in the early stages. You would potentially exclude them from intensive exercise in the presence of LV dysfunction. And we don't actually fully understand the significance of scar in our athletes as yet, but certainly if we did find scar, these individuals need to be kept under long-term surveillance. So how do we assess the risk in our athletes with myocarditis? So when we take a look at markers of risk following myocarditis, certainly ongoing raised serum cardiac troponin in someone who's recovering, an impaired LV function in those who are apparently recovered, ongoing inflammation or on CMR or extensive scar are markers of risk. And this brings me to the possibility of myocardial scarring on CMR individuals with myocarditis. So in this study by Grani, where they looked at 670 patients with suspected myocarditis with a median follow-up of just under 5 years, 15% were diagnosed with a major adverse cardiac event, including 4% of deaths, and 44% of this group showed late gadolinium enhancement. When they looked at the annualized events rates for MACE and the annualized events rates for death, the presence of late gadolinium doubled the risk of MACE and death rates. So how do we use CMR to guide decision-making in our athletes with myocarditis? So if you have a high suspicion of myocarditis, if there's a high pretest probability for myocarditis, the advice is to arrange a CMR for your athlete. Once you diagnose myocarditis, these individuals should be restricted from competitive sports or intensive exercise for a period of 3 to 6 months. You should be considering repeating their CMR in a 3 to 6 month period. And if they've got evidence of ongoing inflammation or impaired left ventricular function, they should remain restricted from competitive sports and intensive exercise. But should you identify a normal CMR and further tests demonstrate normal biomarkers, troponin, no evidence of complex arrhythmias, and or on exercise, then they can go on to compete in all sports. Those with stable or declining late gadolinium and a normal left ventricular function, from my perspective, I would make a case-by-case decision and keep these individuals under surveillance. And those with extensive late GAD, and I'm talking more than 20% of the myocardium with LV impairment, certainly these individuals should be abstaining from high intensity exercise. So I've already mentioned that raised troponin levels, impaired LV function, and ongoing inflammation and scar are markers of risk. But to this, I would also add electrical features. So more than 500 premature ventricular complexes on a Holter or complex premenstrual beats, and increased premature ventricular complexes with exercise, particularly those arising from the left ventricle. So what are the exercise guidelines in individuals with myocarditis? So these were published by the European Society of Cardiology in 2020. And what they recommend is that we comprehensively evaluate these individuals with imaging assessment, exercise stress testing, Holter monitoring, after they've recovered from the acute phase of myocarditis to assess their risk of exercise-related sudden death. Returning to all forms of exercise, including competitive sports, should be considered after 3 to 6 months in those who are asymptomatic, have normal troponin and biomarkers of inflammation. They have normal left ventricular systolic function on echo and CMR. There's no ongoing evidence of inflammation or myocardial fibrosis. They have a good functional capacity and absence of frequent or complex ventricular arrhythmias on Holter and exercise testing. Amongst individuals with probable or definite diagnosis of recent myocarditis, participation in leisure time or competitive sports whilst active inflammation is present is not recommended. Participation in moderate to high intensity exercise for a period of 3 to 6 months after acute myocarditis is again not recommended. And participation in leisure exercise or competitive sports involving high intensity in individuals with residual myocardial scar and persistent LV dysfunction is not recommended. What about the prognosis in athletes with COVID-related myocarditis in those who have a normal left ventricular systolic function and absence of complex ventricular arrhythmias? I have to say the data is limited in this area. There is a lack of knowledge and it does require more work. In this one particular study, they followed these individuals up for a median of 130 days, and during this period, no events were recorded. What about surveillance of individuals with myocardial scar who wish to exercise vigorously? Certainly from my experience, I would keep them under 6-monthly assessment in the first 12 months. I would be repeating their CMR in the first 6 months. And I also consider wearable ECG monitoring during training shortly after returning to play. So here is one such example of an athlete who had myocarditis, who's got one of these wearable devices and is able to transmit data during training and during their rest periods. And the cardiologist can evaluate whether there is an increase in burden in their ventricular complexes, whether there is any non-sustained VTE, which would put them at higher risk. So in conclusion, the prevalence of myocarditis following COVID infection or any other viral illness is low based on clinically guided CMR data. The presence of cardiac symptoms is the best predictor of myocarditis. Athletes with a diagnosis of myocarditis should rest for a period of 3 to 6 months. And following recovery, risk stratification should include assessment of biomarkers of myocyte necrosis, left ventricular function, cardiac arrhythmias, and the presence of myocardial scar. And the short-term risk of a fatality in athletes with mild COVID-19 infection is low. Thank you.
Dan, thank you very much. Sabi, thank you very much. We'll now switch talks, and I'm now going to give an update on research and latest insights in myocarditis. And this will be a shared session, myself and Dan Bromage from King's. So I'll just share my screen. And if you could just let me know that you can see my slides.
Yes, we can.
Yes.
Thank you. So the first, there are 2 areas that I would like to highlight on. One is the diagnosis, and then the second thing will be what causes myocarditis. So from a diagnostic perspective, one of the big conundrums has always been, is this myocarditis? Is this an infarct? Is this something else? And this has been a challenging area. So we've had some recent interesting data looking at the role of MERS within this domain. MERS are small single-stranded non-coding RNAs. They play a role in regulation of gene expression, and one of the things that's been interesting is, can you identify these in the bloodstream, and are they specific to myocarditis? Like, how can we use this to distinguish from, for instance, an acute myocardial infarction or a PE or some other cause of LV dysfunction? So this is work led from colleagues in Spain, but with validation in a number of groups, where they looked at some of the patterns and profiles of MERS across the spectrum and identified that there, in animal studies, that there were a couple that were very specific to myocarditis and that helped to distinguish from an infarct. And then when they extrapolate to the human population again, they see that this very specific MER is unique to the myocarditis cohort. It's very different to patients with a Minot curve, to myocardial infarction, with a very high sensitivity specificity. So I think this is going to be an interesting test going forward. It's not yet ready for prime time. People are looking at this in different cohorts based on ancestry, gender. But I think if we can use this as a test, this would be a great tool, particularly in the sort of patients where it's really unclear what the underlying etiology is. The next step will also be, can we use this test from a theranostic perspective? So not just diagnosis, but in some way from a treatment perspective. So watch this space, but very interesting and a good early start in that differential diagnosis. The second question that patients ask is, why have they got myocarditis? Everyone gets a flu-like illness, everyone gets a viral infection, and yet only a subset of those patients will go on to develop myocarditis. So that's the first thing. And then secondly, we see in small clusters that there seems to be a familial predisposition, suggesting that there could be a genetic basis within that may account, at least for a proportion of patients, that go on to develop myocarditis. So a number of colleagues on the talk and in the States have tried to address this. And we've drawn insights from dilated cardiomyopathy, where 10 years ago, 15 years ago, dilated cardiomyopathy was very much a random disorder. It was either viral, post-viral, or it was iatrogenic. And yet we know that about 30% of dilated cardiomyopathy is post-viral, has some sort of viral etiology going on to cause the cardiomyopathy. And more recently, we've also seen that there's a number of genes that seem to either make patients predisposed or susceptible to developing dilated cardiomyopathy. Of these, the commonest is the titin gene that I'll discuss in a moment, but we're also seeing defects at other levels, desmosomal genes that affect the gap junction, filament C, and also the lamin gene. And so one of the things that we've been interested in is, how can these genes affect patients with dilated cardiomyopathy? Titin, as we said, is the commonest, and titin is the largest protein in the body. It acts like a spring, a scaffold within the myocyte to help function and to help the normal regulation of the contractile function. We know from a number of groups, this is work from Stefan Heymans, that where you have a defect in the titin gene, these patients are predisposed to abnormal myocardial energetics, they get greater fibrosis, and they get greater rhythmic disturbance. So in work led by Amrit Lota and supported by the Janssen's and Myocarditis UK charities, we looked at a large cohort of patients presenting with acute myocarditis to question, is there a genetic predisposition? We focused on our own cohort within predominantly West London, where every patient that presented with an acute diagnosis, we tried to enroll within the study. And this was very much a patient and DGH collaboration, for which we're enormously grateful. We then validated our findings in a completely independent cohort in Holland, in work from Netherlands from Stefan Heymans' group. When we look at our cohort, there are a number of things, even without looking at genetics, that are very interesting. Firstly is that it's a predominant male disorder, male presentation disorder. There's an overwhelming greater number of males compared to females, and that's interesting. Why should that be? But also we tend to see that it's very much a disease affecting younger patients, but it's not unique to just the young. There seems to be some differences in women where they seem to present at a later stage and later age. And again, many questions. This study raises as many questions as it hopes to try and attempt to answer. But one of them is, why is there this preponderance in males? Why do women present at a seemingly later stage? And again, examples of some of the patients within the study. So they all presented with acute myocarditis. They all had classic MR criteria. Within the Dutch cohort, they all had a biopsy, or the majority had a biopsy confirming the diagnosis. And you see this typical pattern of bright signal on the stir imaging within the areas that are affected, that correlate with areas of signal on your latent enhancement imaging in conjunction with a typical history and a troponin rise. So all meeting the criteria. And this is really the headline figure. When we collate our samples, the Dutch and the London cohort, what we see is that there are certain genes that seem to predominate. So two of the key genes are those in the titin and those in desmosomal genes that affect the gap junction, and that classically tend to present with a more arrhythmogenic cardiomyopathy phenotype. So the arrhythmocardiogenic genes, the desmosomal genes, are particularly affecting the gap junction, the titin gene, as we've seen, particularly affecting contractile function. And then as we interrogate the link with ejection fraction, what we're seeing is that patients that present with acute myocarditis and have preserved ejection fraction seem to have an increased burden of desmosomal genes, whereas patients with a reduced ejection fraction seem to have a preponderance of the titin gene. And overall, when we looked at the collated cohorts, we're seeing a gene abnormality in about 8% of patients. So 1 in about 12 of patients have a gene abnormality. So what that means is that we're at a starting point where we can see that a monogenic gene abnormality somehow at this point associates with developing myocarditis, and future work will show whether it's in some way causal, whether there is a predisposition, and that's going to be an area of much interest, because if you can identify patients before they've had myocarditis, that probably is your first starting point to trying to work out a cure and preventing them from getting this horrible condition. So the other question that's addressed is, does this somehow link to arrhythmia and to worse outcomes? And again, we're not powered in this study to be able to do that with certainty, but we are seeing is that there are significant trends. So where you have a gene abnormality, you do seem to have a trend towards greater arrhythmia, greater heart failure, but future work will address that in much greater detail. And that's really the mainstay of one of our next big themes of work. And so at the moment, our paradigm that we believe explains what's happening in myocarditis is that you have a cohort, 8% in this study, that have a monogenic gene abnormality where you have a big gene defect with a big size abnormality. And then there's likely to be the other end of the spectrum, the 90% or so that don't have one of these genes identified, where we think that there is either an oligogenic or a polygenic predisposition. In other words, a number of small genes that are coming together that somehow or other, either through the immune pathway or fibrotic pathway or all of these, predispose these patients to developing myocarditis. And that's very much seems to fit with the paradigm of what we're seeing in dilated cardiomyopathy. And again, that should come as no coincidence, because 30% of dilated cardiomyopathy appears due to myocarditis. It also explains for the first time why it is that patients seem to have this overlap in phenotype between an arrhythmogenic cardiomyopathy and myocarditis, and the fact that really there is this direct link between these conditions. So I think diagnosis and I think gene abnormalities are going to be really, and the genetics going to be really interesting, giving us greater mechanistic insight into the condition. I'd now like to hand over to my colleague, Dan Bromage, who's a consultant from King's, who will also talk about his really exciting work, particularly in terms of therapy. Thank you.
Hopefully sharing my screen now. Thank you for the invitation and good evening, everyone. I'm going to talk about some of the new things in the treatment of myocarditis, with a particular focus on some of the things that we don't know so much about. So the current paradigm for immunosuppression in myocarditis is based on some quite old now ESC working group guidelines that recommend immunosuppression only once active infection has been ruled out by endomyocardial biopsy. You can see further down also suggests that immunosuppression may be considered on an individual basis in infection-negative lymphocytic myocarditis. So really making the point that viral infection should be ruled out. With that in mind, who should be treated with steroids? Well, I think we have good evidence for treating patients with giant cell myocarditis, one of the severe and often fulminant forms of myocarditis, with immunosuppression. And lots of this work is derived from research from Leslie Cooper, who we've already heard from this evening. On the left, all patients with giant cell myocarditis. And on the right, you see better outcomes in those treated with immunosuppression. The issue is that giant cells are seen on endomyocardial biopsy and might not appear for 1 to 2 weeks, making decision-making in acute myocarditis in the in-hospital setting much more difficult. There are no randomized controlled trials in this area, and the guidelines are based on case series, expert opinion, and pathophysiological considerations. But when looking in retrospective observational analyses at acute but not giant cell myocarditis, there seems to be no benefit, or at least no association with benefit of immunosuppression. So I think one of the interesting questions that we need to answer is whether we're targeting the wrong patients or whether steroids are the wrong treatment. If we consider whether these are the wrong patients, particularly with respect to restricting to those patients who are virus negative, it's increasingly recognized that viruses, and particularly parvovirus and HHV6, may be found in a large proportion of patients who don't have myocarditis. It might be the virus-triggered immune reaction, especially cardiac myosin-stimulated CD4 positive T cells, that are important, and a viral genome, which might be a bystander, may not be an absolute contraindication. Therefore, it's important that we look at what clinical features are associated with poor outcome, because it might be those features that predict a response to steroids. So when we think about the clinical features that are associated with adverse outcome, two that immediately come to mind are a fulminant presentation. So those are presentations with myocarditis that are hyperacute and often require mechanical circulatory support in the early hours of admission. And you can see on the Kaplan-Meier curve on the top left that patients with fulminant myocarditis, shown here in black, have much lower rates of transplant-free survival compared to those with a non-fulminant presentation. And from our own work, even just simply stratifying by presentation ejection fraction, so those with a preserved compared to those with reduced ejection fraction do better, those with reduced ejection fraction do worse. So perhaps these are the clinical variables that we need to be identifying to work out who might respond to steroids, rather than anything based on endomyocardial biopsy. Importantly, a trial looking at just this question is now recruiting. It's called the MIT trial, and it's randomizing patients to a control arm who will receive placebo versus an intervention arm who will receive pulsed IV methylprednisolone. Now, importantly, the inclusion into this trial doesn't require having an endomyocardial biopsy and exclusion of a viral genome. So this is going to give us very important information about steroids in the in-hospital setting prior to endomyocardial biopsy. Or is it that steroids are the wrong treatment? We know, I think, from myocardial infarction that non-specific one-size-fits-all immunosuppression has failed to ameliorate heart failure after MI. And in the meta-analyses of corticosteroids in MI, they weren't associated with benefit in the biggest and best conducted studies. And actually, there might have been an association with harm caused by ventricular rupture. So increasingly now, multi-omics are well established in myocardial infarction. And we're just starting to see these approaches being applied to myocarditis, which is very welcome. So this is a study using bulk RNA sequencing of human patients with myocarditis. And using gene ontology analysis, they identified several pathways that seem to distinguish giant cell myocarditis from other forms of myocarditis. They ran this data through a drugs database to find potential treatment pathways. And one of the important things they identified was upregulation of IL-1 beta signaling, which could potentially be treated by anakinra. So carrying on with the parallels with myocardial infarction, we know that colchicine can inhibit the inflammasome as well as inhibiting neutrophil chemotaxis to prevent expression of IL-1 beta. So colchicine theoretically could be an attractive treatment for myocarditis. This is in MI, where we've got the first evidence that targeting inflammation acutely after MI can improve outcomes. So this is very welcome and also something of considerable interest for patients with myocarditis. Interestingly, I think there's very limited clinical evidence for colchicine in myocarditis, which is a surprise given its role in pericarditis. There was one small abstract at SCMR conference showing that 63% of patients discharged on colchicine showed complete resolution of myocarditis on CMR. But of the 21 patients who did not receive colchicine, only 38% had resolution of myocarditis on CMR. Now, of course, this is retrospective and observational, but has set the scene for another randomized study called the Old-Timer study. This is taking patients with lymphocytic myocarditis, an ejection fraction less than or equal to 49%, so not normal, and NYHA class 2 or 3 symptoms. The primary endpoint is ejection fraction as measured by cardiac MRI, and patients will be randomized to either placebo or colchicine with an endpoint at 24 weeks. Similarly, we've already mentioned anakinra as an agent that can target IL-1 beta, and there's a randomized study to look at the effects of anakinra in acute myocarditis, where patients will be randomized to a control arm receiving placebo or an intervention arm receiving anakinra with a composite endpoint of the number of days alive free of any myocarditis complications. And the results of that are awaited with interest. I think what we can say is that the future of myocarditis therapy is likely to be much more personalized than what we've seen at the moment, based on deep immunophenotyping of patients. I'd like to finish by talking about whether we should target fibrosis in myocarditis with preserved ejection fraction, or MPEF. So these patients, we don't really know how to treat them, and typically their outcomes are quite good, but not always. So we know that in patients who have myocardial injury, we see an influx of pro-inflammatory cells and different cell populations infiltrate the heart in sequence, ultimately resulting in fibrosis or scar, as seen on the MRI image on the bottom left, with this white rim around the lateral wall. The ATAMI registry of 374 patients with CMR-proven myocarditis, with mean left ventricular ejection fraction more than 62%, investigated a combined endpoint of cardiac death, appropriate ICD therapy, resuscitated cardiac arrest, and hospitalization for heart failure, and interestingly observed worse outcome for patients with a particular pattern of scar, and that pattern was those patients with scar in the anteroseptal wall. So despite having a normal ejection fraction, the presence of scar on MRI does predict a worse outcome. We wanted to see if any treatments might be appropriate for this, so we began by meta-analyzing preclinical models of myocarditis, finding 52 in all. And when we looked at a fibrosis endpoint, we found that several medications actually, but including ACE inhibitors, were associated with a reduction in fibrosis compared to control. Now, I show this last slide with the caveat that it's very preliminary data, but we've tried to follow this up in humans and have observed an association with improved outcome in patients with preserved ejection fraction who are treated with ACE inhibitors at the time of discharge. And this is something we're going to look into more and hope to bring you the answers in the published literature shortly. I thank you for your attention, and we can take any questions at the end, I think.
Thank you so much, Dan, and thank you so much, Sanjay. So I think, as Dan said, we're going to look to do questions at the end of all of this. So the next, we're going to move on to the next speakers. So there's two speakers for the next set of talks. First speaker is Gautam Sen, who is working with me as a PhD fellow and is a cardiology registrar in Wessex. He's going to present a case of ours, just give you a quick 5 minutes about this, and depending on how we go for time, I can fill in a little bit about some of the stuff that might be of interest from the patient perspective with this. It's been quite an interesting journey for the patient involved with this. And then we're going to get a direct patient experience from Sharon Williamson, and very much looking forward to hearing that as well. So thank you so much, both of you, for giving us your time this evening. And Gautam's going to go first, so thank you so much.
Thank you very much, Dr. Stader, for the invitation. So we wanted to highlight this case because, in fact, in the last few months, we've seen a couple of similar cases to this at our hospital at King's College. And we sort of feel it's quite a hot topic at the moment in this field. So this was a 21-year-old female. She had no past medical history of any cardiovascular disease, not on any regular medications. She did have a family history of a bicuspid aortic valve in her grandmother, and her other grandmother had a history of lupus, but nothing related to acute coronary syndromes or myocarditis at all. She did not smoke and drank alcohol socially. So she'd had a 2-year history of palpitations and mild chest discomfort, which had been looked at by one of the local cardiologists. And she'd only had a 24-hour ECG, which showed some ectopic beats, which was sort of well controlled with beta blockers. On this occasion, she got admitted to her local emergency department with acute chest pain, severe breathlessness, and palpitations. She was very clear in her history that she had no viral prodrome at all. And in fact, all her blood tests showed negative viral screen, a normal autoimmune screen, and her inflammatory markers were essentially normal as well. The only abnormality in her blood test was an extremely high troponin of greater than 12,000 and an ECG showing normal sinus rhythm with an infralateral T-wave inversion. Now, due to her young age and the lack of family history for heart attacks or acute coronary syndromes, she was referred for a cardiac MRI rather than for a coronary angiogram. So this showing the late gadolinium enhancement pictures for her cardiac MRI. So we've got a basal short axis slice and the mid short axis slice. And she had extensive late gadolinium enhancement in the basal to mid inferior walls and her lateral walls, and some extension into the septum. Quite a dramatic MRI picture, really, and quite a severe myocarditis type picture here. So following on from this, she was started on treatment for myopericarditis with non-steroidals and colchicine as per the guidelines. However, she couldn't really tolerate either of these very well. Was tried with some steroids as second-line treatment, but struggled with these as well. And unfortunately, then she represented a few months later with a raise in troponin again, but this time she had some reduction in her LV function as well on echocardiogram. She was referred to a transplant center for a biopsy and further workup, but fortunately she improved and didn't end up getting the biopsy in the end. She was then referred to our myocarditis clinic at King's for a third opinion on what the potential diagnosis here was, even though it could have been myocarditis, but there was a diagnostic dilemma considering she was having ongoing symptoms, getting very severe chest pain to the point that she was completely housebound with this. Her troponin was, however, normal at this stage, and just for completion, we wanted to complete her investigations. We performed a repeat MRI, and in fact, this was completely unchanged, really, and we performed some extra mapping, which I can show here, and her T2 mapping for myocardial edema was essentially normal. So it seemed that her myocarditis process had settled down quite nicely, which made us think of what her potential differentials could be here. Was this a simple viral myocarditis? However, she had no viral prodrome. Her viral screen was completely normal. Her immune screen was normal as well. Could this be cardiac sarcoid? But on her MRI, we'd not seen any extra cardiac features such as lymph nodes or any lung changes. Her ACE was normal. And typically, sarcoid presents with a bit more of an acute coronary, rather than acute coronary syndrome, presents more as a conduction disease type of picture. And in her case, all her conduction was essentially normal. It sort of left us with, could this be an arrhythmogenic cardiomyopathy or ACM? And in fact, we're seeing a little bit more now that a hot arrhythmogenic cardiomyopathy can present as a hot myocarditis. So she was discussed in our inherited multidisciplinary meeting and went on to have some genetic testing based on how severe her symptoms were and the florid nature of the cardiac MRI. And in fact, her genetic mutation came back, showing a pathogenic variant in the desmoplakin gene, and therefore confirming a diagnosis of ACM. Just my final slide. So ACM is a genetic heart muscle disease characterized by substitution of the ventricular myocardium by a fibrofatty tissue. The cardiac MRI late gadolinium enhancement pictures can be very similar in a very severe myocarditis and in ACM. And in fact, a large number of patients who've been involved in studies now have received a clinical diagnosis of myocarditis, have now had their diagnosis changed based on histology and then the genetic testing. So the important point that we want to leave really is that ACM and myocarditis can mimic each other, and the medical history, especially the family history, is very, very important.
Thank you so much. So one of the things I think that's interesting with this case and difficult with this case is to go from the starting point with this lady to the point of diagnosis. I would say all in took about 1.5 years. So it's a very, very long journey for the patient who's stuck in the middle of this. Particularly, she's had 2 admissions with troponin rises, further admissions with chest pain to hospital, and is, clearly desperate for a diagnosis. And of course, in the end, ends up coming to us for a third opinion on the back of her local cardiologist knowing that we had an interest in this. So, it was quite a long and difficult journey for her. The local inherited team actually didn't want to do genetic testing on her. It's really made quite a difference in her case. So maybe something we want to talk about further later on in the meeting. So lovely. Thank you so much, Gotham. So going to move on to the next talk. So Sharon's going to speak to us next and give us very much the personal patient's perspective on this. So thank you so much for giving us your time this evening.
Hello, hi everybody. Hi. Thank you for having me. I really do appreciate the opportunity to share my story. I do have to say that I'm actually blown away by some of the information that I've been given this evening. At one point, I think, I'm sure I heard Daniel say to our Siri. I mean, that's how blown away I am with the information that I've been given. But I actually started off on my journey as an athlete who was running 30 miles a week. I was working full-time as a senior social work practitioner, and I was looking after my elderly parents and my daughter. I presented myself to A&E on 7 different occasions because I wasn't feeling very well. And on each occasion, I would actually go with my suitcase packed, thinking that they were definitely going to keep me in at that time because of my symptoms and how I was feeling. My symptoms were that I was projectile vomiting. I didn't find it difficult to run 30 miles a week. However, I did attend a spinning class and couldn't understand why some people that were less experienced than me were able to not only finish the class, but go on to do other things. And once I was admitted into hospital, I was told that I needed a pacemaker, sorry. And then I was told that I needed an ablation from the outside in. And then I was told that I needed ablation from the inside out. And then I was told that I had 12 days to live and I needed a heart transplant. And then I woke up wearing somebody else's heart. So my journey has not just been a physical one, it's been a mental one as well, to go from being physically fit. I think I was turned away from the hospital 7 times because at the time they were looking at 10.5 stones of muscle and somebody that was just physically fit. I actually remember calling, or my parents calling the ambulance at home. I wasn't feeling particularly well, and the paramedics turned up and did ECG and told me I was having a panic attack. But I now know that wasn't a panic attack, it was my heart failing, and that went on for 7 months before I had my heart transplant. Now, I'm saying what I'm saying, and I'm not this isn't a blame game. This isn't about blaming, but there were situations during myself telling 2 specific hospitals that I wasn't feeling very well and what my symptoms were, and me not being believed. That's how I felt. I know my own body. I've never been ill in my entire life. Never had any symptoms of anything. And panic attacks is not something that I'm accustomed to. I don't panic about anything. So that was strange to me. Yeah, I ended up with a heart transplant, and because I had giant cell myocarditis. So I'm actually on medication at the moment. I have to self-medicate 4 times a day. Most of those, as you know, will be immune suppressants. And I still take prednisolone steroid. I've been told that the myocarditis can come back, and that's the reason why I have to take it. So that's my story.
Oh, sorry, come in as well, Sanjay. So I was going to say thank you so much for that. I mean, I think sometimes this is a story that we hear, and I think the going in and out of A&E is obviously extremely distressing. I suspect, presuming you've highlighted it. Would I be right in saying the worst part of it at the very beginning, by the sounds of it?
Oh, absolutely. Yeah, not just the worst part of it. I mean, they weren't even sure. It was only in the last stages. I mean, if you can imagine, they thought I just needed a pacemaker, and that went from needing a pacemaker to needing ablation from the inside out. And when that failed, it was ablation from the outside in. And when that failed, it was, well, you're going to die if you don't get a heart transplant. But I think it's important also to recognise, and I've had this debate with my transplant centre in Edgbaston, the fact that once you've had a transplant, and if you're not feeling well, you still have to return to the same A&E where you was before, that you presented yourself, where you was told there was nothing wrong with you and you need to go home. But also you've got your low immune system. So you're actually exposed to people. And I think it's the same with people who have cancer. When your immune system is low, you're still expected to sit in the same A&E with people that have perhaps a lot of bacteria, germs, and whatever else. So you're at risk then as well, not just before, but also after. Yeah.
I suppose what I was going to ask you, I mean, you can see there's lots of people on the conference, and there's a whole variety of what those people will do. Some will be patients, some will be junior doctors, some will be senior doctors. From the medical side, so many of the patients on this will probably resonate with all this. You know, it took me a while. You see the case that we presented before. It took a while to get to the end point of saying, okay, this is what it is and this is what we need to do about it. And I suspect if you asked our patient the same thing, she'd probably tell you the same sorts of things, particularly about what went on at the beginning. So looking to try to sort of think ahead and be sort of, I suppose, constructive for the doctors on the call, what do you think we could do better? How would you, looking at your journey with this, what do you think we could have done better for you with this? What can we learn, I suppose, is sort of what I'm getting at.
Yeah, I think for me, it's not to judge. My story is about not judging a book by its cover, because on the exterior, I looked healthy, I looked well. They couldn't understand why I was in A&E. And they did run tests. I mean, they did ECGs and other tests. I remember for one whole week, I had to present after 7 days with a bucket full of my own urine. I don't know what that is. I'm not medical. And I was also put on a dose of bisoprolol. but it's interesting because I was listening to what, let me just see if I can remember her name. Sabia was saying about not doing any exercises. So I wasn't told this. I was told to go on, I was given some medication called bisoprolol, and I wasn't told not to exercise. So for me, I was still getting up at 6 o'clock in the morning and running 10 miles that day. And then a day later, perhaps running another 10 miles, 2 days later, another 10 miles. So I think it's imperative for the information regarding any suspect of whatever it is a patient might have, what not to do. Don't just say it. I know for a fact that I wasn't told, because I would have followed those instructions. I'm quite good at that. But also I was told that I wasn't on the right level of bisoprolol. So that again, it was I'm not used to taking medication. So when I was given it, I took it. But to find out that it wasn't the right dose was a shock. But also being told that I was told not to exercise was a shock. I mean, they weren't aware that I had giant cell myocarditis or myocarditis. So they didn't say don't exercise because you've got myocarditis. Even at that stage, I was just given the bisoprolol. So I think for me, it's make yourself clear. And it's also important to explain to the patient what you're actually doing or what's going on, because a lot of what was going on with me, I didn't understand. I'm not medical. I'm a social worker. So, when they were coming to me to sign things and they were telling me that, I needed ablation. Well, what's ablation? I needed a pacemaker. Well, why? There's a lot of information to take in if you're not medical. And some of the things that I was being told, I really didn't understand.
Okay, so it is often the case, and having done this many times, a lot of this is communication, I think, ultimately.
Absolutely. Mm-hmm.
And also bearing in mind, particularly younger, fitter people, and I think many of the medics on this call will resonate with this, that things are more easily missed, exactly as you said, because we think you're more well than you actually are. Absolutely. Yeah. Okay, can I say thanks, Sharon? Thank you so much. I'm sure I'm going to speak on behalf of everybody on this and wish you all the very best for the future with your heart transplantation, and I hope everything goes well for you.
Thank you.
So Sanjay, do you want to come back in? I mean, we've slightly run over here. Do you want to do anything with the Q&A? I've sort of been filling in a bit of the Q&A.
No, sure. so we've got a number of questions. I'm conscious of the time, so we'll allow a couple of minutes, and then I'd like to ask Andy Janssens just to give the closing words. So the first question, and Dan, this is really one targeted for you. In someone with a viral myocarditis, would you give them steroids now then?
Do you want Dan
Bremage, sorry. Yeah.
You want to come in, Dan?
I think the current recommendations are that if a patient has no evidence of a viral genome on their biopsy, but I think some of the consensus is moving towards treating patients with steroids who have adverse signs like a fulminant presentation or reduced ejection fraction in the absence of any obvious signs or history of viral infection. That's sometimes difficult to ascertain, but in the most severe cases, it may not always be necessary to wait for steroids, to wait for a biopsy. But as I say, this is a very evidence-free area, and be interested to know what other people's practices too.
Sure. And the follow-up question is that another one colleague on the call has asked, steroids are often given for acute COVID illness. Does that, and if you've got a patient who's also got myocarditis as an acute presentation, does that concern you?
We should be very clear that there's no evidence of harm from steroids. Most of the contraindication to steroids from the presence of virus is theoretical. So there are no studies that I know of, or no large studies showing harm. So no, it doesn't concern me. And certainly the treatment for COVID as an acute illness with steroids has a very strong evidence base, and much stronger than anything we have in myocarditis.
Sure. And Dan Sado, moving on quickly. Genetics in that last lady, that beautiful case presentation, question from the audience, how did that tangibly change her management?
I can tell you now the first and the most major thing it's done for, because that's quite a hot off the press, which is where that case comes from. The first thing it's done for her is that she was desperate for an answer. So forgetting anything else, it is now clear, because other things had been floated, could this be sarcoidosis, for example? You actually now have an answer and have a diagnosis for, I can tell you psychologically, the biggest impact of this without question for the patient, I think if you asked her, would be she is now happy that we know what we're dealing with and can take things forward. It has quite an impact on family. So her first degree relatives are going to be screened. From our perspective, it also changes some of the way we may want to follow her up. Questions around whether we might want to think about ICD implantate. There's all sorts of things that it sort of changes the ballpark. The other thing, of course, it's also done is it actually means that Dan Bromwich and myself actually won't end up seeing her again. Now she'll end up in follow-up in a specialist inherited clinic. So I would say it actually does change quite a lot with her.
And linked to that, a follow-up question again from the audience is, who then should be getting genetic testing in 2022 when they present with myocarditis?
It's interesting because this is debated, and I think I mentioned that the local inherited service, this lady actually refused to do it. So, you know, this isn't easy. I think for me, I think Amrit talked about it at the beginning, you need to have a bit of index of suspicion. If you look at this lady's story, there was clearly no viral prodrome at any point with this. She's had it twice in a fairly short space of time. It's fairly florid. The late GAD looks quite impressive for viral myocarditis. There's multiple things with her that push me in that direction. I have to be honest, my own practice, Sanjay, and I don't know what your view on this is. Once I start seeing septal involvement with late GAD, it's always, for me, a bit of a red flag of, is this just, sometimes it is, I think, but it's a big red flag for me once you're seeing it going that far around. But
yeah, no, I think we would share that. Where you see a large stripe, a linear band of late enhancement, be that in the septum or the infralateral wall, classic presentations, they invariably turn out to be gene positive. And there is that ring-like pattern now that we're starting to see within MR. Another question, we'll have two final questions, and then we'll push on. And again, Dan Bromwich, this is probably best for you, which is, it's great to say you'll treat patients if you've got an MRI scan or if you've got a biopsy, but in the absence of those, given the limited availability in some centers, if you've got a patient with reduced EF, would you still treat them with some form of immunosuppression?
I think it's very tricky to treat patients with immunosuppression without a confirmed diagnosis. There are guidelines from the ESC for clinically suspected myocarditis, but I think certainly in that kind of patient, it would have to be a kind of MDT case-by-case discussion.
Okay, no, fair enough. And then the final question, in the interest of time, Amrit, question from the audience: how do you distinguish chronic from acute myocarditis?
So I think it would be important to use the whole range of investigations that were mentioned. So patients with a more chronic myocarditis, you may see a grumbling troponin that may be increased and stay persistently increased for some time. You might see changes on the MRI scan as well, with ongoing edema on the T2 mapping sequences. And you should be able to quantify that now as well and be able to track the change over time. Of course, it is a big challenge, and we could talk about this for quite a long time, and how to go about treating such patients. But I think those are the main insights.
Great, no, thank you. Well, I'm enormously grateful to all the speakers, including my co-chair and all the speakers, for a fabulous range of talks that I've learned lots. It's been super informative. We're also very, very grateful to Leslie Cooper for taking the time out from his busy schedule, and to you, the audience, for both taking part and for your questions. And if I may, I'll now hand over for the final closing words from Andy Janssens, who's really made all of this happen from Myocarditis UK, the patient-fronted charity. Andy, over to you.
Yeah, no, thank you very much, Sanjay. And I think I would echo your words. Thank you to everybody for a very detailed presentation. And I think for us as a charity, over the last 10 years, in the last few years, there have been some massive strides in clearly what's a very complicated affliction. But I'd go back to Sharon's interview, really, in terms of her experience. And from our point of view as a charity, we have many similar stories at that stage presenting to A&E or general practitioners. And our sort of key aims are awareness, prevention, and early detection. But out of all that, it's the awareness actually that we need to get over to general practitioners, but particularly the A&E and the NHS. If you've got young adults coming in presenting with panic-like symptoms or persistent viral issues, then they should be thinking about myocarditis. And I think one of the things we're trying to achieve, and I think we'll struggle, Sanjay, is to get some sort of NHS paper out there, to hospitals with symptoms and what to think about when people present. And we've had a few instances via our charity with young adults who have heard about myocarditis, have gone to their doctors and actually said, well, look, think about it. And we've got a few particular examples where young adults presenting with flu-like symptoms have actually had myocarditis. So it all starts with awareness, and we'll continue the good job and support research going forward to find some solutions. And ultimately, we are heading towards a path to think about cures as well.
Thank you very much. And thank you to everyone for taking part. We will close there, and enormously grateful to everyone. Thank you and enjoy the rest of your evening.
Thanks, everyone.
Thank you.
Bye.